Next, we're going to segue into survivorship and kind of the particulars about things that patients often don't discuss, women in particular, mainly because, as we know, we often are worried about everybody else and less about ourselves. So it really becomes an intent to ask the correct questions when you have patients in your clinic for the follow-up. The follow-up is not just about, oh, you don't have cancer recurrence, but it really needs to be about how you are functioning every day in this new realm of survivorship. Any physician knows that they can't do everything on their own, and any good physician surrounds themselves with even greater people. So I have the distinct honor of presenting two of our very good people and staff who are part of our women's team. I'm first going to introduce you to Tracy Garrett-Reed, who is originally from Houston, Texas. She received her BSN and MSN from Prairie View A&M University, completed a family nurse practitioner track in 2012. She received her DNP from the University of South Alabama. She has dual certification as a family nurse practitioner and as an advanced oncology certified nurse practitioner. She is a member of multiple nursing societies. She has been involved in this community treating patients with cancer, and she's currently my nurse practitioner, and I can't do anything without her. I'm very blessed. So welcome, Tracy. And Shauna Moron is a PA practicing at UMC. She also is the extended arm of the GYN cancer program. Prior to becoming a PA, she taught nutrition education to formerly incarcerated women in her home state of California. In addition to her passion for women's health, she is a clinical preceptor for the PA students at the LSU PA program. She has a master's degree in physician assistant studies. This is from MCPHS University in Boston, and a Bachelor of Science in Public Health from Cal State San Bernardino. Please help me welcome both of these women who help to give a voice to our patients every day.
Good morning. I am Tracy Garrett-Reed, and I work with Dr. McKinney. I love her too, and she's also my sorority sister, so that's even better. So I will be discussing the psychosocial long-term effects of breast cancer treatment. I have no disclosures. In the U.S., breast cancer is the most common female cancer and the second most common cause of cancer death in women. The American Cancer Society estimates that in 2024, there will be over 300,000 new cases of invasive cancer, over 56,000 cases of DCIS, and over 42,000 women will die from breast cancer. So these are some of the treatment options available for breast cancer: hormonal therapy, chemotherapy, biological therapy, which has definitely been a game changer. Patients are able to tolerate these drugs better than traditional chemotherapy, radiation therapy, and also surgery. With the advances in breast cancer treatment, patients are living longer. Surveillance, epidemiology, and end result program collects and publishes data on cancer incidence and survival from cancer registries. So for the 5-year survival rate for localized breast cancer, it's 99%, and regional being 86%, distant disease 31%, and a combined survival rate, 5-year survival rate of 91%. So for this discussion, I'm going to focus on depression and body image related distress, but I want to touch on a few of the other long-term effects of breast cancer treatment, such as neuropathy. It's a common side effect of chemotherapy. Patients are typically started on duloxetine or gabapentin, and if these symptoms aren't well managed with these medications, they can be referred to neurology. Lymphedema is a side effect that depends on the extent of surgery and axillary radiation. Fatigue is also common. Arthralgia and menopausal symptoms are commonly seen with endocrine therapy. So what is depression? The National Institute of Mental Health defines depression as a common but serious mood disorder that causes severe symptoms which affects how a person feels, thinks, and handles daily activities such as sleeping, eating, and working. Some of the patients may say, oh, I have persistent sadness, decreased energy, I can't sleep at night, I don't have interest in things that I had before, becoming withdrawn, decreased sexual desire, increased anger, suicide ideation, and these symptoms must be present for at least 2 weeks. So this is the NCCN guidelines distress thermometer. So it just goes over 5 topics: physical, emotional, social, practical, and spiritual concerns. This is a great tool to use to start the conversation about one's mental health. Going through cancer treatment is definitely no walk in the park, as we know. Medical professionals should be providing emotional support to all patients at each visit. So this is definitely a great tool to use to get that conversation started. Interpreting the distress thermometer. If a patient's distress score is greater than or equal to 4, they should be asked more questions about their emotional well-being. How are you feeling today? Tell me a little bit more about what you're experiencing at home. And if their score is above 4 or greater and you don't have the time to speak to your patient at that moment, you should refer them to the correct specialty, such as onc-psych, the social worker, chaplain, or a spiritual counselor. Ideally, patients should be screened at each visit, but sometimes that's not the case. So they should definitely be screened at their initial oncology visit. So treatment options available for depression. Psychotherapy, and optimal management of their symptoms that are contributing to the depression, medications, of course, mental health treatment and follow-up, patient and family education. Also consider a referral to psych, consider a referral to your social worker or chaplain. What is body image? So body image is an internal representation of one's outer appearance that involves the mental representation, of one's own body and related emotions within an overall sense of bodily self. So body image can positively or negatively impact one's quality of life. These are a few body image related distress issues that we see in practice in some solutions or treatment options that are available. So post-surgical scarring, so you can refer them to plastic surgery for scar revision. You can also have them use a topical silicone gel to help with their scar. Breast asymmetry, you can again refer them to plastic surgery for reconstruction. or send them to the local DME company to be fitted for a breast prosthesis. Loss of nipple sensation. This depends on how sensate the nipple was prior to surgery, as to what the impact will be post-operatively. And alopecia, which is secondary to chemotherapy. So patients can be given a prescription for cranial prosthesis in this instance. Radiation skin changes. I always tell patients to keep their skin well hydrated with Aquaphor, vitamin E oil. Weight fluctuations. So with the hormonal changes and treatment, and the treatments that patients may be on can affect their fluctuation in weight. So they can be referred to weight management clinic and or the dietitian. Lymphedema. They can be referred to occupational therapy to be fitted for compression sleeve glove. Additional treatment options are psychotherapy, support groups, consider a referral to a sexual health specialist, and also a referral to psychiatry. I am missing a slide, but this is my conclusion. So in conclusion, stress to your staff how important the distress thermometer is. I feel like it should be treated as a vital sign. They should definitely be reporting anything that is greater than or equal to 4. Provide emotional support at each visit for all patients. Dealing with psychosocial issues can be difficult and time consuming, so please refer them to the appropriate specialties such as onc-psych or your social worker if you don't have the time to speak with them about this, to give them the best care possible. Please be kind, be empathetic, and most of all, be available. Thank you. These are my